There you go. That's right. Stand up, shake it out. It's only going to be about half an hour, but deep breaths. There you go. Good. It's hard act to follow there. Those are some great talks, and as a radiologist, I spend the vast majority of my time sitting in a dark room talking to myself. So this isn't my typical environment. So if it's a little stilted, you'll know why. I also apologize for not having the exact title of what I was going to be talking about able to be in your bulletins there. But we're going to spend a little bit of time talking about clinical indications for breast MRI specifically today. I think this is something that warrants a discussion and should be evidence-based, and we're going to go through some of those studies, look at the evidence behind its use when it's appropriate, and hopefully learn something today about breast MRI. No financial disclosures. So breast MRI is a very important diagnostic tool for imaging the breast. We know that it's highly sensitive for the detection of breast cancer, and it allows for detection of otherwise occult breast carcinoma, so cancer that's not seen. Excuse me for a second here, I'm going to raise this up a little bit. Breast cancer that's not seen by our other imaging modalities. As with all of our imaging tests, we know that the evidence that we should be using data to support our imaging. It should be evidence supported. And there have been a number of clinical trials looking at MRI in particular for certain clinical indications. So understanding the data as it relates to its use is very important, trying to weigh the relative advantages, that being early detection, decreased re-excision rates, with disadvantages. Obviously, MRI, as opposed to mammography, is a much more expensive test, and there's also a possibility for false positivity. It's not 100% specific. So we're going to look now at some specific clinical scenarios. MRI has been studied most for cancer detection in two particular groups of women, screening of women at a very high risk for breast cancer, and that's now supported by major medical organizations, including the American Cancer Society and the NCCN. And then we're going to look at its use in staging of women with newly diagnosed breast cancers. There are still questions that remain about its impact on outcomes, and the NCCN guidelines currently give it an optional recommendation. So looking at both those two things will take up the majority of the next 20 minutes or so. There are also other indications, which we're going to discuss briefly. At the end, evaluation of patients undergoing neoadjuvant chemotherapy is an important one, as well as using breast MRI in the setting of a metastatic axillary adenocarcinoma when you don't know where the primary is. And then at the very end, we'll talk briefly about problem solving for suspicious or equivocal clinical or imaging findings, and whether to or not to use it in that particular setting. And I say implant evaluation because we also will use it occasionally in the setting of women with implant integrity issues, but we're not going to talk about that today. So let's talk first about high-risk screening. We're going to look at a case. This is a 63-year-old woman with a BRCA gene mutation. And she had a personal history of left breast cancer, had breast conservation 8 years ago. She's been having benign follow-up mammograms. These are CC whole breast views, left breast, prior on the left, current on the right. The breast is heterogeneously dense, but there is no mammographic abnormality. MLO views, same story, heterogeneously dense breast tissue, clips from axillary dissection from prior breast conservation therapy, but no mammographic abnormality and no change. This is a T1 weighted contrast enhanced fat suppressed image of the breast. The radiographic right is the right, and then the image, or the breast on your right is the left breast, but the enhancing irregular mass, and this was done on the same day as those mammographic images, demonstrates this invasive ductal carcinoma. Again, an axial and a sagittal image demonstrating this irregular enhancing mass, which was proven to be an invasive ductal carcinoma. We know that in these very high-risk patients that the sensitivity of mammography is limited, and multiple single and multi-institution trials of screening MRI added to mammography, and some have also included ultrasound, have been performed in this particular population. The study designs in the populations have varied. Most commonly, you're looking at gene mutation carriers, or those in that greater than 20% lifetime risk due to family history, and all have demonstrated that MRI has had a higher sensitivity than our other imaging tools, so ranging from 71 to 100% versus a much lower and wider range for mammography and ultrasound. This is a chart showing comparative sensitivities of mammography and ultrasound and MRI over a variety of different studies. And at the bottom you see 84.2% being sort of the cumulative average of MRI sensitivity versus ultrasound and mammography being quite a bit lower in these particular patient populations. Across all studies, the cancer yields for mammography alone were 14 out of 1,000, MRI alone 22 out of 1,000, and when combined, the highest yield or the greatest impact was 42 cancers out of 1,000 women. Interestingly, no added benefit was found in these studies when ultrasound was added to those two modalities. Now, obviously, there's potential limitations. The specificity isn't perfect. Specificity ranges from 81 to 97%. There's a theoretical risk for a higher recall of patients undergoing biopsies and then not being found to have cancer and higher biopsy rates. The balance to that is that from the studies that have been performed, there's actually a higher positive biopsy rate with MRI than there is for mammography, meaning there's more patients who would undergo an MRI-guided biopsy and end up having a diagnosis of cancer than what is currently accepted for the positive biopsy rate for mammography itself. Also, as a limitation, cost. Obviously, it's much more expensive than mammography. There have been few studies of cost effectiveness. The ones that have been done have shown the greatest benefit in younger women, 35 to 54-year-old women with the BRCA1 gene mutation. And there's also a lack of data on long-term outcomes. There is evidence for a downward stage shift with MRI detection, meaning we're finding cancers at an earlier stage, which has been a surrogate measure for impact on mortality. So what are the current American Cancer Society recommendations for MRI screening? Well, it's currently recommended for particular high-risk groups, BRCA gene mutation carriers, first-degree relatives of BRCA gene mutation carriers but who are untested, and then those with a lifetime risk of 20 to 25% or greater, as defined by the BRCA Pro or any of those other models that Dr. Jones was discussing. It's also recommended as an annual screening tool, and this is in addition to mammography, so not as a replacement to mammography, but as an adjunct in those who've had radiation to the chest between the ages of 10 and 30, those with other genetic mutations, Li-Fraumeni syndrome, and first-degree relatives, and Cowden. And the last one there I'm not even going to attempt to pronounce in front of you, but basically syndromes that significantly increase your risk for many different neoplasias, including breast cancer. So looking again at another case, this is a 30-year-old with a history of Hodgkin lymphoma, status post-chest radiation, and getting a breast MRI in the setting of screening. These are images, CC and MLO views of the right breast. The breast is heterogeneously dense. There are no mammographic abnormalities. She underwent a breast MRI and was found within the right breast, so the breast that's on your left, the right breast, to have a mass at 5 o'clock, which on ultrasound-guided core needle biopsy was found to be an invasive ductal carcinoma. Now, the American Cancer Society has recommendations that basically state that there is insufficient evidence to recommend for or against using breast MRI in the setting of moderate risk. So what is moderate risk? Well, moderate risk is those women who fall into a lifetime risk category of 15 to 20%, those who have had high-risk biopsy in their personal history, so women who have had biopsies of atypical ductal hyperplasia, atypical lobular hyperplasia, or LCIS, and then those women who have either heterogeneously or extremely dense breast tissue on their mammogram. We know they're at increased risk. They fall into this moderate risk category. And as of now, women who are in a personal history of breast cancer also fall into this moderate risk category. And the ACS does not recommend annual screening MRI in women of average risk. So what about those women with a personal history of treated breast cancer? There was a survey sent out to, I think it was over 375 different practices around the country, members of the Society of Breast Imaging, and asking about the use of breast MRI in this setting, and over 2/3 of the practices said that in their institutions they were actually screening these women pretty routinely. And at the University of Washington, we screened them pretty routinely if they had had a personal history of breast cancer. We know they're at an elevated risk, and we know that early detection of these second cancers with mammography is known to decrease mortality. And at the same time, we know that mammography, while important, is imperfect, with a sensitivity estimated at around 50 to 65% in these patients. And initial studies have suggested that the diagnostic performance of MRI in these women with a personal history alone may be similar to that of those women with a genetic or family history. This is some data out of the University of Washington. We used annual screening MRI in a lot of patients with personal history of breast cancer. PH, personal history of breast cancer. GFH is genetic and family history. And these are basically just showing that the cancer yield and recall rate and positive predicted value were very similar, and in fact at times improved in screening women with a personal history as opposed to women with a genetic and family history. So MRI performed just as well, if not better. So I believe it shows promise as an adjunct to mammography in this patient population. This currently falls into the ACSs. They can't recommend for or against, and so there's a lot of variety in the practice of and use of it around the country right now. At UW, it certainly wasn't used infrequently. It was at the discretion of the clinician and the patient. Just incidentally, it ended up being oftentimes younger patients, patients with really dense breasts, and patients who had had mammographically original cancer. And I think that's kind of been our practice here as well, it seems. Another case, this is a 38-year-old woman, asymptomatic, personal history of right invasive ductal carcinoma, had a mastectomy and chemotherapy 6 years prior, no genetic or family history, and had multiple negative left mammograms. You see the left mammogram on the left, heterogeneously dense breast tissue, no mammographic abnormality, and then the MRI on the right demonstrating findings of mastectomy with implant reconstruction within the right breast, and then an irregular enhancing mass measuring 15 millimeters within the left breast, which underwent subsequent MRI-guided biopsy and was found to be an invasive ductal carcinoma. Another case of a 50-year-old woman, asymptomatic, personal history of left breast IDC, status post-breast conservation therapy and chemotherapy 1 year prior, no genetic or family history, and benign left mammograms. Again, mammogram demonstrating evidence of prior breast conservation therapy, heterogeneously dense breast tissue, but no mammographic abnormality. And on her breast MRI within the left breast, we see susceptibility artifact marked by the arrows where the clips are, and anterior to that, non-mass enhancement, which was again biopsied by MRI guidance and found to be invasive ductal carcinoma recurrence. So now we're going to turn and spend a few minutes looking at newly diagnosed breast cancer using MRI in that particular setting, both for ipsilateral extent of disease and for contralateral screening. I don't know of any institutions in this country that are still doing unilateral breast MRI. We are solely do a bilateral exam. So if you're out there and you're ordering breast MRIs, it should be a bilateral breast MRI regardless of the indication. Let's look at a case really briefly. This is a 60-year-old woman, asymptomatic, annual screening mammogram. This is the right breast. The breast is heterogeneously dense. There was a mass in this breast at 12 o'clock found and warranted additional workup. On MRI, we saw not only the mass there, but there was additional non-mass enhancement surrounding this mass, which was biopsy proven to be both the invasive ductal component as well as DCIS, spanning over 60 millimeters, and obviously changing the clinical course of her treatment. So what are our goals for MRI in these newly diagnosed breast cancer patients? Well, trying to define the ipsilateral extent of disease is our goal, to improve the selection of patients for surgery in order to decrease the number of surgeries that they have, decrease the re-excision rate. We want to decrease recurrence and improve survival, obviously. And then we're also using it to screen the contralateral breast in order to find early detection of those synchronous malignancies that we know do happen. The absolute risk of contralateral breast cancer in a woman with personal history is about 0.5% to 1% per year. So over the first 10 years after treatment, there's a 5 to 10% risk of having a synchronous contralateral malignancy, and then trying to coordinate therapy if those are indeed found. Again, another chart looking at numbers or percentages of additional unsuspected ipsilateral malignancy in women who are diagnosed with breast cancer. And in the ipsilateral breast, the average, the studies show that there are an average of 13% of patients who end up with additional disease found by MRI in that same breast. This next one shows the contralateral rate, so percentage of patients with contralateral malignancies found at the time of index diagnosis of breast cancer being approximately 4%. So summarizing those clinical trials, we know that MRI identifies additional malignancy when added to clinical breast exam and mammography at the time of index cancer diagnosis. Interestingly, there have not been clear differences in cancer yields within these studies in subgroups based on breast density, age, or histology of the index cancer. I think it's easy to think, well, this is a fatty breasted woman. We're much less likely to get an MRI maybe on her because we think, oh, it's so clear. Well, interestingly, that hasn't actually borne out in the studies. There's been equal percentages of women with additional disease found if they have fatty breast tissue versus extremely dense breast tissue. And the same goes for invasive lobular carcinoma versus invasive ductal carcinoma. I think it's easy to think it's a lobular carcinoma. We know that that can be much more mammographically occult. We would have a higher likelihood of having additional disease. Well, it ends up being about the same as invasive ductal carcinoma. Now, this is not without controversy. There are a number of controversies regarding MRI and its use in this particular setting. Impact on surgery, there aren't definitive data as of yet. There have been a number of varied methodologies and definitions of impact used when looking at it in this particular setting. The COMES trial, which was a trial published in The Lancet out of the UK. They looked at 1,600 women planned for wide local excision. They had about half of the women, 816, who had MRIs, half did not, and they found no difference in reoperation rates. 19% re-excision rate in patients who had MRI, and the same in women who hadn't had an MRI, and that was at 6 months. Now, there certainly were limitations with this trial. Interestingly, preoperative tissue sampling was not done at all the centers in this trial, meaning that 28%, or 16 of the 58 women who had MRI initial cases, which ultimately went on to mastectomy, could have been avoided if they'd had that area that was found to be suspicious on the initial MRI sampled and found to indeed be benign. So preoperative tissue sampling would have been very helpful in potentially modifying the outcomes that they reported in this study. There was also variability in the technique of their MRI exams and in the interpretation. They reported a contralateral detection rate of 1.6% versus what I showed you earlier. And Brennan did a meta-analysis looking at contralateral detection rates, and his was 4%. So that raises the question of whether or not their technical standards were really up to par. And re-excision rates for both groups at 19% was low relative to U.S. Surgical practices, and so people wonder, are these results really generalizable to the U.S. practice techniques? And there is an ACRIN trial. ACRIN is the American College of Radiology Imaging Network, a very highly respected group of people, and there's a trial forthcoming on this particular issue. Again, controversy over whether or not there's really an impact on recurrence or survival. The published data currently are not definitive. There was a retrospective review by Solon looking at patients with early stage cancer treated with breast conservation therapy with and without MRI, and they reported no change in local recurrence rates at 8 years of follow-up. And at the same time, I think if you read that study well, you wonder about a potential selection bias that went on in that study. And interestingly, they had variable timing of the MRIs that were done. Only about half of the MRIs in their study were performed before the patient had surgery, so that's certainly going to impact their outcomes. What about mastectomy rates? There's certainly a controversy there to say that, if a woman gets an MRI, she's much more likely to have a mastectomy. And there was a study out of the Mayo Clinic looking at that, a retrospective study looking at all early stage breast cancers from 1997 to 2006, and they reported a significant association between an increase in mastectomy rates and an increase in MRI use. That was their big conclusion. At the same time, they had mastectomy rates increase even more steeply in women who did not have an MRI. And I think decisions regarding when women choose to have mastectomies and when they don't is very complicated, and variables for why they choose mastectomy were not included in this trial. So decisions regarding reconstructive surgery, whether or not they'd had genetic testing, and the many variables around that particular decision to have or not have mastectomy. So currently the use, as I said, amongst practices is varied. Some practices, no patients are getting breast MRI at the diagnosis of cancer. Some studies or some institutions such as the University of Washington, every woman essentially is recommended to have a breast MRI. In fact, they won't make it fully through the tumor board process unless they've had a breast MRI. And then some patients are being chosen for breast MRI in this setting based on their tumor type, so invasive lobular carcinoma, or whether or not they have extremely dense breast tissue. And we're hopeful for quality data and results from this Akron trial that should be forthcoming. So now I want to take a minute and turn and look briefly at a couple of other indications. Evaluation of patients on neoadjuvant chemotherapy first. We know that this is being used increasingly in patients with locally advanced breast cancer, and the utility of MRI is really seen in being able to visually see that decrease in size, the change in breast kinetics over time on these patients with neoadjuvant chemotherapy. We also there was an Akron trial recently published, Akron 6657, that looked at the MRI and compared it to clinical assessment in relationship to pathologic correlation. And they found and concluded that MRI was actually a stronger predictor of pathologic response in the adjuvant than clinical assessment alone in patients with stage 2 or stage 3 disease. And I know that we've been using that here, and I think having great success with that. Using breast MRI in the setting of metastatic axillary adenocarcinoma of unknown primary. This is a case of a 39-year-old woman. She had palpable right axillary lymphadenopathy, a normal clinical breast examination. These are CC views and MLO views of her breast, a heterogeneously dense breast tissue, no mammographic abnormality. There are BBs within the right axilla demarcating the sites of palpable concern. She went on to targeted ultrasound, was found to have abnormal axillary lymph nodes, which underwent sampling and was proven to be an adenocarcinoma of unknown primary. On her breast MRI, which was performed, the small arrow there shows a mass in the upper outer quadrant, which on ultrasound-guided biopsy was proven to be the primary invasive ductal carcinoma in her breast. Now, this setting is rare. We know this is less than 1% of all breast cancers. Typically, these cases are from the ipsilateral breast, but oftentimes they're not identified on clinical breast exam or on mammography, and so certainly an identification of a primary malignancy in this setting by MRI can impact treatment. So the last thing I want to talk about is problem solving, and this ends up being kind of a problem, and I'm so far, and I have only limited experience out in private practice, but at the University of Washington, you couldn't get a breast MRI in this setting. If there was a question on a mammogram or an ultrasound, the radiologist at that diagnostic workup had to decide, I'm either going to sample this thing because I'm worried enough about it, or we're going to follow it, but we're not going to do an MRI to kind of figure it out. And so in private practice, it's been more variable. But I think it's important to kind of look at sort of the data and decide, should we be using it in this setting? Because it can be very confusing, I think, sometimes. It's been advocated by some for equivocal mammographic ultrasound or clinical findings to use to determine whether or not we need, to do a biopsy. Well, if the MRI is positive, it looks suspicious, maybe we'll do a biopsy in that setting. And there have only been anecdotal reports of utility, and the data is there, but certainly quite sparse. The problem is that in order to avoid the biopsy of a finding, the negative predictive value of MRI must be sufficiently high to definitively exclude a cancer. Meaning, if that study is negative, are you confident enough in the negative predicted value of that particular study to say, I don't need to biopsy anything by these other imaging modalities? And unfortunately, that has not yet been demonstrated with MRI, and particularly given the relatively low likelihood of malignancy at which the standard of care is biopsy. So if on our other imaging tools, if in our mammography and our ultrasound, the likelihood of something being a cancer falls above 2%, well, that warrants a needle biopsy by whatever modality it is that you're looking at it on. If it's under that, then it falls into that probably benign category, or it's something that should just be called benign. Two studies looking at the negative predictive value of MRI found rates of about 85%, 76 to 85%, but certainly not high enough to feel confident that you could be excluding malignancy if you had a negative MRI in that setting of trying to solve a problem. Other cases that may be useful in the problem-solving setting would be ipsilateral nipple discharge with a negative standard workup. There was a study looking at 34 patients in this particular clinical context, and MRI identified 9 of the 12 cancers in that particular setting. So I think it's surgeon dependent and clinician dependent and patient dependent too in these settings, but I think my recommendation is really to use it very judiciously given the lack of data that we have in this setting. And in general, a finding that's equivocal by our traditional mammography and ultrasound workup should be treated as suspicious and undergo tissue sampling in order to truly exclude the possibility of underlying malignancy. So in summary, MRI is the most sensitive tool, imaging tool that we have for breast cancer detection. We know that it identifies otherwise occult breast cancer in a variety of clinical settings. And I think reserving MRI for applications supported by the literature and understanding its strengths and limitations is really critical for betterment of outcomes in our patients, and hopefully further studies of cost effectiveness and impact on the short and long-term outcomes will help to refine our use of breast MRI. I think it's certainly a powerful tool, but I think making sure that we're using it in the right clinical context is really crucial. So thank you. These are many of my mentors at the University of Washington who helped with many of the slides that I showed you and the data that was presented, and these are my munchkins. So thanks.